Welcome everyone. I am Pam Fury, System Manager for CDI. This session is focused on documentation of diagnosis related to respiratory failure. As a reminder, much of the content presented can also be found on your tip sheet pocket guides and/or the posters that are placed in the physician documentation areas. I first would like to review the guidelines related to encephalopathy and distinguish between encephalopathy, delirium, and dementia. Encephalopathy is simply delirium that has a known cause. So, a medical condition that causes delirium is encephalopathy. Acute or subacute generalized alteration in a brain function that is due to a systemic underlying cause. Encephalopathy is reversible and it resolves when the underlying cause is corrected and structural changes do not occur. So delirium is really a disturbance it's kind of a symptom, right? It's a disturbance in the attention and the awareness that develops over a short period of time, typically a symptom or a mental disorder. Delirium is secondary to encephalopathy, the etiology of the encephalopathy. So it's a symptom that's associated with the underlying cause of encephalopathy. Perhaps you could document something like toxic encephalopathy due to dilantin causing the delirium. Delirium also can be secondary to a post-procedural or senile dementia with delirium. Now, dementia is an actual diagnosis, a recognized diagnosis, which is defined as it has a certain baseline that is permanent, right? So, a dementia patient can also have encephalopathy, and it's important that you distinguish that the patient's baseline is dementia, but with encephalopathy. So a patient can actually have dementia, delirium, and encephalopathy. The delirium is a symptom. Dementia is their new normal, which is their underlying baseline, and they can have encephalopathy on top of that. So a dementia patient has encephalopathy when there is an acute mental status alteration that is associated with a metabolic or toxic factor that does improve and return to a baseline of dementia when the cause is corrected. There are different types of encephalopathy that are the acute encephalopathy, so I want to distinguish between the types. So there's metabolic. You all know this, but metabolic is due to things such as a fever, dehydration, electrolyte imbalance, acidosis, hypoxia, an infection, or organ failure. Toxic encephalopathy is an acute toxic encephalopathy is typically refers to the effects of a non-medicinal drug or a toxin or the adverse effect of a medication. Septic encephalopathy is a clinical term that represents a manifestation of severe sepsis. Acute hepatic really describes the spectrum of neuroimpairment in patients that have severe end-stage liver disease. You also can have hypertensive encephalopathy, acute or subacute consequence of severe hypertension that's marked by a headache, confusion, stupor. Some patients can be obtunded. You also can have hypoxic encephalopathy, which is permanent chronic brain damage due to sustained hypoxia. And there are other types of encephalopathies that can be likely due to things like an acute CVA. Also, I don't have it on this slide, but it's important to note that encephalopathy is sometimes caused by, it can be multifactorial. So it is okay if a patient does have multifactorial encephalopathy, but you need to list out which type. Like they could have metabolic in addition to septic encephalopathy. They could have sepsis, but they could also have electrolyte imbalances and or dehydration or something else causing the encephalopathy that's metabolic. I'm going to take you through a couple scenarios of clinical findings, how they were treated, what the risk factors were, and what your options for the proper diagnosis of encephalopathy are. It's often an overlooked diagnosis that's not documented. So the first scenario is the clinical findings of a patient. The reason for admission is, quote, altered mental status secondary to a urinary tract infection. Altered mental status is a symptom, sign and a symptom. It is not a diagnosis. It's typically due to something underlying. Um, this patient also has a past medical history, which was notable for advanced dementia, which is written on the H&P. The reason the patient was hospitalized was due to altered mental status with a diagnosis of a UTI. That's what was written in the discharge summary. All of this is correct clinically. Some of it has correct diagnosis, but it does not have complete diagnosis written. This patient was treated with IV lactated ringer solution, IV Vanc, IV Bactrim, or PO Bactrim on discharge, and also IV ceftriaxone. What's the risk factor? This patient has advanced dementia as their baseline in advanced age and also has a UTI. So your diagnosis options in this case is what type of encephalopathy is typically due to a urinary tract infection. It's usually metabolic encephalopathy. So the proper diagnosis in this scenario would be acute metabolic encephalopathy secondary to a UTI in addition to advanced dementia, which was present on admission and is now resolved. Remember, encephalopathy is short-term treatable and can be resolved, but the advanced dementia was present on admission and is not resolvable. Another option could be in this particular scenario that the patient has chronic advanced dementia without acute metabolic encephalopathy, not typically likely when there's an alteration in behavior or altered mental status. Altered mental status was indicating it's something different than the baseline that's normal for the patient, or you're clinically unable to determine. We'll always give you those options if we send a query. Okay. The second scenario, here's the clinical findings for the second scenario. A patient presented to the emergency room with altered mentation. Upon arrival to the emergency room, it was noted that the patient had a glucose of 959 on the BMP, no anion gap, and no acidosis. The physician wrote that this is, quote, this is most likely HHNK. That was in the transfer summary that was written. Another clinical finding is the patient has paranoid schizophrenia. As her medication wore off and her blood sugar became normalized, she began to be more paranoid and psychotic. That was also written on the transfer summary. So what was the treatment? This patient received IV fluids, long-term insulin, and short-term insulin. What are the risk factors in this patient? The patient has chronic underlying mental disorder, which can be delirium, a paranoid schizophrenic. They are non-compliant with their medication. That's a risk factor. They are hyperglycemic and they had acute kidney injury. So what are your diagnosis options here that would be a more appropriate diagnosis for this patient? You could write altered mental status, multifactorial, secondary to metabolic encephalopathy, which is due to the HHNK, dehydration, and uremia, in addition to the paranoid schizophrenia, which is present on admission. So there's a lot happening with this patient, right? They have a number of underlying conditions. They have dehydration contributing to the metabolic encephalopathy. They have the HHNK contributing to it, and then they also have a baseline of paranoid schizophrenia. So once again, a proper diagnosis here could be mentioning the symptom and what the symptom, what caused the symptom. The altered mental status is multifactorial secondary to metabolic encephalopathy due to HHNK, dehydration, and uremia, in addition to the paranoid schizophrenia, which is present on admission. If you don't believe the patient from the assessments in the clinical presentation, you could also write the diagnosis of just paranoid schizophrenia without encephalopathy. However, it did say the patient came to the emergency room because of altered mentation. So that tells me that it's not that patient's baseline, or once again, you're clinically unable to determine. Okay, scenario number 3. The clinical findings on this patient, they presented with, quote, minimal verbal response. Patient is confused and unable to follow commands. The other clinical finding was a seizure disorder with a new onset. This was witnessed at the emergency department. The final diagnosis on the discharge summary was 1, altered mental status secondary to dehydration that has resolved. That was in the discharge summary. But however, that is not a diagnosis. Again, altered mental status is a symptom of something underlying. The other clinical findings were the patient, had a GCS score of 9, um, and also a GCS score of 11. Initially, they were confused. They had a score of a 4, and they withdrew from pain. They did improve, and they were incomprehensible with a verbal score of 2. So remember, encephalopathy is reversible, acute and short term. This patient was treated with some IV fluids, and the risk factors for this patient was dehydration, seizure disorder, and advanced dementia. So what type of encephalopathy is this, and what is the cause of the altered mental status? So typically in the query, we would present you with the diagnosis options. The first one would be altered mental status multifactorial from metabolic encephalopathy, which is secondary to dehydration, and post-ictal delirium from the seizure activity. So remember, delirium is from an underlying cause, right, which was the seizure. And then the encephalopathy is acknowledging the cause of the delirium. Or you could simply have written a diagnosis post-ictal delirium from seizure activity only, or once again, clinically unable to determine. Another scenario, clinical findings are the patient presented to the ED. They were found lethargic. They were given Narcan 2 milligrams, and then the patient appeared to respond immediately after given the Narcan and returned to their baseline within an hour. That was on the H&P. The discharge diagnosis indicated there was a Tylenol overdose after co-ingestion of alcohol, Norco, and Valium. And then another diagnosis that was written in the discharge summary was altered mental status due to number 1. Again, that's all very clinically accurate, but it's not written in the form of a diagnosis that we can capture. In this case, the patient was treated with IV Narcan, and the risk factors were the ingestion of Norco and alcohol combined. So the diagnosis options that we would present on a query or that you consider documenting here are toxic encephalopathy, secondary to ingestion of alcohol, Norco, and Valium, all present on admission and resolved. Or you could write altered mental status without toxic encephalopathy, secondary to the Tylenol overdose, POA, or resolved, clinically unable to determine. But all the clinical evidence and criteria are present for the proper diagnosis of toxic encephalopathy in this case. That's all I have regarding encephalopathy. You're welcome to reach out to any of the members of the CDI team, and I just want to thank you all for being a valued member in the care of the patients and the proper documentation of the diagnosis related to the patients. Thanks so much.